Testing.
I think we're running okay.
Today's seminar series speaker was Dr. Paul Nathan, Consultant Medical Oncologist at Mount Vernon Cancer Centre, Northwood, Middlesex. Thank you for coming to talk to us today. Your seminar was entitled Metastatic Melanoma, Biology, Immunology and Drug Discovery Combined to Transform a Lethal Disease. Until recently, metastatic melanoma has had a very short median survival time. However, advances in understanding the biology of the disease and the immunological interaction between host and cancer have resulted in the identification and exploitation of new targets. This has transformed the outcome for many patients. Paul, could you tell us about some of these discoveries?
With pleasure, and thank you for the invitation. I'm a medical oncologist. I treat melanoma, and many of my patients have advanced melanoma. And historically, outcomes for those patients was very poor. Median survivals were in the order of 6 to 9 months. And it was a disease that was pretty refractory to conventional chemotherapy. And what's changed has really been quite remarkable over the last few years, because we've made advances in two distinct areas at the same time, both of which have now been proved to result in significant improvements in overall survival. And we're in the process of learning how to maximise those advances and to see whether or not we can use those two potential areas together. The two areas are distinct. One is with targeted agents against the MAP kinase pathway, so particularly against the mutated BRAF gene product and other targets in the MAP kinase pathway. And then the second area is with the new generation of immunotherapeutics. And as I say, both of those have had a profound impact upon the way we manage patients now. So about 50% of cutaneous melanoma patients carry an acquired mutation in the BRAF gene, which is an activating mutation. And what I'll be describing in my talk is the development of drugs that target that activated BRAF gene, and also the beneficial effects of not just directing treatment against that target, but also another target, MEK, which is the next enzyme down the MAP kinase pathway. And we've now got a number of clinical trials proving survival advantages with those two treatments against those two targets. And just to give you a sense of the difference it makes, for instance, a few weeks ago I saw in my clinic a woman who I had seen 4 weeks before, moribund, and she was lying on a bed at another cancer centre, another hospital I should say, hardly able to talk, just about able to communicate. She was still able to swallow, and she had a brain full of metastatic melanoma as well as disease elsewhere. And patients like her would have been given put on the care of the dying pathway a few years ago. We rapidly found out that her disease carried a BRAF mutation. She started treatment, and when I saw her next in clinic, she walked in with her family, and we were able to have a conversation. And so the disease management acutely has changed dramatically. So for patients, the 50% of patients who carry those mutations in their tumour, you can have a dramatic cytoreductive effect. The lumps get much smaller, people feel massively better, and you successfully palliate advanced disease. The problem with those treatments is the durability of response, and most patients don't have a very durable response, with duration of response between 6 to 9 months on average, depending on whether you're using one drug or two drugs. So that's an average, so obviously there are a group of patients who do better than that, but there are a group of patients who do worse than that. So one of the things that we need to figure out is how to prolong those sorts of responses. The second thing I'll be discussing is the new immunotherapy drugs. And the thing about immunotherapy is if you turn on the immune system in the right way, you can get durable disease control. So you're not looking at months of benefit, you're looking at many years of benefit, and a few of us, myself included, think for some patients we're curing. Now that's extraordinary, because we've gone from a disease that's got a 6-month median survival to a subgroup of patients who are being cured with advanced disease. But again, we're in the early stages of figuring out how to use those drugs best, whether to use them on their own or in combination, and there are a variety of different sort of combinations. So it's been a huge sea change. My summary slide in my talk is that I'm a medical oncologist, but I don't give chemotherapy anymore. I give these targeted drugs and immune therapies, and that's the way to go. And what's interesting is that those, particularly the immune therapy advances, are being mirrored in a number of other cancers now as well. And there's no doubt that what we're after is around durability of control. So, in other words, if you're taking somebody in their 50s or 60s, you can control their disease for 30 years. Well, even if you don't get rid of it, if it's controlled for 30 years, that's probably all right by most people. I think we're just starting to be able to do that for some of our patients.
Indeed, that's really quite a remarkable turnaround in the disease profile. For those who don't have that sort of genetic makeup of their cancer, or stop responding for whatever reason, are there any new therapies out there that could offer them some hope?
Well, the immune therapies are not genetically targeted, so they are applicable for all patients, whether they have BRAF mutant disease or BRAF wild type disease. So one of the areas of interest is if somebody's got BRAF mutant disease, whether we should use BRAF inhibitors first or we should use immune therapies first, and there's a lot of prejudice but not a lot of data to instruct what to do. But so you have the opportunity for sequential treatments there. And likewise with the immune therapies, for somebody who's got BRAF wild type disease, there are a couple of targets that are clinically accessible now, and there are more coming through. I guess the underlying point of the question, though, is the recognition that the majority of patients ultimately don't get durable benefit. I think we're not far off a third of the patients having very significant benefit, but that means the majority are not. So the only way you can progress the field is by recruiting to clinical trials. And many of my patients who've done well over the years access drugs which are now currently available, but were not at the time outside a clinical trial. So the important thing is that these patients are referred to centres that are running appropriate clinical trials to give them opportunities to access novel treatments that may have an impact upon resistant disease.
We look forward to seeing these developments reach the clinic and everyday practice. Dr. Nathan, thank you very much for coming to speak to us.
Pleasure.